This program is brought to you by Stanford University. Please visit us at stanford.edu.
There is a lot of interest these days in the issue of hormones in young women versus older women, and so I want to go through this new thinking. It's not totally new, but what I want to start with is how we got into the whole issue of hormones and heart disease to begin with, and it starts with a really simple sex difference in rates of coronary heart disease. And this is actually an article that hits, for me, the point, which is the myth and paradox. What people have been saying is that women were protected against heart disease until menopause, and then they lost their estrogen and they lost their protection. And so this particular analysis tested this, or looked at this issue and tried to map the sex differences, the ratio between men and women, how it relates to where menopause is. And I think that the big problem that we see is there's no convincing evidence that there's a huge inflection right at the time of menopause. There's clearly evidence that age is an issue, but this is still this mystery. What is going on when we're 30 and 40, probably more than at the time of menopause. So one thing you're going to hear from me is the feeling that if there is a timing issue, we need to back it up and figure out something that's more in the 40s as opposed to homing all the way into the 50s. And WHI didn't have anyone in their 40s. Now, there was a huge observational literature addressing this issue. It actually came out, the first two big papers that came out in the New England Journal of Medicine in 1985 were back-to-back and diametrically opposed. And that was the famous Framingham study that said the women on hormones had twice as many heart attacks, and the famous Nurses' Health study that said they had half as many heart attacks. So it started out as a controversy. And from that point on, I think we have a lot of problems in the literature. I think we have publication biases. What you really start to learn is that these journals will take something that's hot and sexy, and they're not going to take something that's neutral. And so what we have, because of a lot of complaints about this, we now have to register our clinical trials so that we know all the trials that exist instead of just the ones that make it into these high-profile journals. That said, we sure try to get into the high-profile journals. So we go right along with it. Now, by quick background, I'll let you know that the first big trial that the NHLBI conducted on this, called the Pepi Study, was just looking at risk factors. Stanford was one of the 7 sites in the Pepi Study, so we've been doing this a long time. And this was a study where there was a test, we were testing estrogen alone and then estrogen with different progestins, cyclic, continuous. This was kind of the beginning of the prem-pro phase where we started using daily progesterone instead of cyclic. But the interesting thing, again, in terms of how the media present things, is this was all, the media and the medical community, this was all about the benefits. It raises HDL, it lowers LDL. And there wasn't very much said about the triglycerides, and the C-reactive protein wasn't even on the map yet. In fact, I remember when Mary Cushman sent us the first draft of that paper and said, there's something wrong. C-reactive protein goes up. It's supposed to go down. And that's the bias, it's supposed to. And this is something that you hear over and over, and I've lived 20 years of this research with one surprise after the next because we are expecting something, and we don't always get what we expect. Like the lights going on. So the next one that we conducted, we were one of 20 sites, and actually Kathy Barra, who's here, is the real key of the Stanford site, was a study of women with heart disease to test the question whether adding estrogen and progestin, starting estrogen and progestin could prevent a second heart attack. And the HERS trial was very much expected to show benefit, and the big surprise was even though HDL went up and LDL went down, the triglycerides also went up just like in Pepi. There was absolutely no benefit over the 4-year period, and I think even the bigger, that actually didn't surprise me. In fact, I had a bet, and I think Kathy still owes me lunch. But what happened that was the surprise was there were more heart attacks in the estrogen and progestin group than the placebo group in the first year. And so this idea of early harm, later benefit, kind of emerged. And I think this was a spin, if you ask me, if you actually start to look at who created that story. Wyeth funded hers, and I think Wyeth had a lot to do with that story, and it kept them going for a while. But in fact, within the next couple years, a whole series of intermediate endpoint studies came out, surrogate endpoints, that pretty much confirmed no benefit, no benefit, no benefit, early harm. And nobody was giving us any real evidence, including hers, which was continued for another 2.7 years, I think. So everybody was eager to find out about primary prevention. Can you prevent the first heart attack? And the Women's Health Initiative was kind of seen as the next story that's going to make it right. How come it's going wrong? And so, as you know, it didn't. But to just give you some real quick background, this study really was 2 trials based on whether you had a hysterectomy or not. So a woman with a hysterectomy would be assigned to estrogen only or placebo, and it was conjugated equine estrogen at the most common dose of the time, and it's still the most common dose. And if they still had their uterus, they were assigned to the estrogen and the progestin to protect their uterus, or the placebo. Same estrogen and medroxyprogesterone acetate. Now, of course, when WHI came out the way it did, everybody said that's the wrong estrogen, the wrong progesterone, even though this is what physicians are prescribing to women. So we have to kind of deal with, well, then we would have studied whatever you were prescribing. And what we had were 2 trials. Large trials, as you see, we have over 16,608 women in the estrogen and progestin, nearly 11,000 women in the estrogen alone. So this is the study of women with a uterus. This is the study of women with hysterectomy. The primary outcome was coronary heart disease, but we had several other outcomes that were built into the monitoring plan and built into our plan to look at the overall picture, and I'm focusing just on the cardiovascular outcomes in this talk, so I won't be getting into any of the cancers. We had hypotheses coming into this, that this is a schematic of the hypotheses just to give you some sense of the relative belief system, I guess. We had all the observational data suggesting a 30% increase or decrease in heart disease, so we expected a huge benefit. We didn't really know about stroke because it was bouncing back and forth. Not enough cases had been reported yet. We did anticipate a risk of breast cancer. We had concerns about blood clots. We did expect benefits to bone. So we had certain expectations, and those were built into the monitoring plan. And the monitoring plan was basically set up with the ability to handle a lot of benefit, some risk, but the overall picture was really what was going to stop the study. And this is basically the monitoring plan, just to review this real quickly. 3 cardiovascular outcomes were built into it. 3 cancers if you had a uterus, 2 if you didn't, and the hip fractures. And then we had this thing that was called the Global Index, which was the first incidence of any one of these outcomes would be added, and you would just keep adding what's happening, what is the total burden of this, this treatment on women, and do they come out looking better off. And the plan was no one of these outcomes would stop the trial. It had to be the outcomes and the overall picture in the same direction. And I'm not going to go through all that. I'm just going to say, as you know, the estrogen and progestin trial was stopped prematurely, almost 3.5 years, a little over 3 years prematurely. Now, what started this off was the breast cancer. But that would have been balanced by the benefit that was seen at that time in hip fractures and in colorectal cancers. So that would not have stopped the trial. Breast cancer would not have stopped it had it not been for the fact that the initial hypothesis was wrong. And that basically what we had were more heart attacks, more strokes, and more blood clots. And so the overall picture, which many of you have seen some version of this, so I am racing through my introduction part here, that basically the picture was excess cases of heart attacks, strokes, pulmonary emboli, breast cancers, fewer cases of hip fractures and colorectal cancer, but those benefits compared to those risks just couldn't make this whole again. So basically we had a situation where the trial was stopped, but these were on preliminary data. So one reason why WHI has continued to publish paper after paper is that we didn't have all the data in when this publication came out. We had to kind of rush to press because we were stopping a trial. We knew this was going to be a shock that was going to be heard around the world. We probably could have done it better. So in defense of the GYNs, we understand that was a nightmare for you. I've been living that nightmare for 5 years now. It hasn't gone away. So the more important point is that we felt that we had to get something out there so the medical community could see, but these were preliminary data, and subsequently we followed them up with the full data set centrally adjudicated. So I want to just quickly start with the estrogen and progestin part of it and clarify that when we finally did have all of the outcomes in, which by the way, when we stopped the trial, the staff didn't know that we were stopping the trial. They still had stacks of paper on their desk where the outcomes that we were hoping to get. So there was a huge flurry to get this all there, and it actually turned out that this was not significant in that the confidence interval was on 1, so we just call it borderline significant. This is the definition that was used in the trial, acute MI plus silent MI plus coronary heart disease death, and we had local and central adjudication. But when we did the updated analyses, we realized that what everybody was upset about when WHA came out was the age of the women. That was the very first thing we heard is your women are too old and too fat. And that was what we had to live with every single presentation. They're too old and they're too fat. And the estrogen and progestin group, I'm not going to show you all those data, but I'll tell you, they were very similar to the US population in terms of distribution of obesity. So they were a perfect population to study this question, and this is the estrogen and progestin group. Now, in terms of being too old, we were really kind of pressed into doing subgroup analyses and looking at what is going on with age. And so this is the first analysis that came out on age that basically for E plus P showed absolutely no effect of age, no benefit in younger women, and this is something that has been totally missed by the recent publicity, that in the estrogen and progestin trial, women with a uterus, there's no evidence at all, any shred of it, that there's benefit in young women. So we'll have to move on to the estrogen-only trial. I do want to quickly say that this analysis also did a year-by-year blow, recognizing that only the first year is the true randomized study, because from that point on, women are no longer included. If they had a heart attack in year 1, they're not in year 2, and so on and so forth. So what you're doing is you're slowly weeding out the vulnerable, and by the time you get to the year 6, 7 of the data, which is not very many women are there, what you have is not later benefit. What you have is the survivors of 6 years of having, or 5 years of having more heart attacks than the placebo group. So estrogen and progestin is one story, and estrogen only is another story. I will quickly say that the estrogen only story is very similar to the estrogen and progestin story for strokes and for VTE, increase on the hormone. And so it's not surprising that a black box label was put into estrogen products after the estrogen and progestin trial came out that basically said we should not be using these hormones to prevent heart disease. And it does go on and talks about lowest effective doses, which we did not study, and so there wasn't great data to support the recommendation, perhaps shortest duration. But that came into play before we even had the estrogen-only study. So a lot of publicity, a lot of women came off their hormones before we even had the estrogen-only trial. So this is a problem that we've been fighting ever since the study came out, is trying to get people to realize that we're talking about 2 different trials and 2 different groups of women. But at any rate, precipitous drops in prescriptions, and I do know that Wyeth has reported that it's still about here. So it has not, this is the E plus P, it has not rebounded. It's not true that women are going back on these hormones at the rate that people think, but we'll get to that, and I'm not defending it one way or the other, because if you're miserable, then this is the best game in town. Now, the estrogen-only trial was very different from the estrogen and progestin trial in that there was not an increase in heart attacks, there was an increase in strokes that I've already mentioned, there was not an increase in breast cancer, in fact it was slightly decreased, And the overall global picture was one that was neutral, not harm. So that's an important distinction. To go to the heart disease issue, as I said, no difference between groups, actually a slight decrease overall, but not significant at all. But we were already really into the need to look at the age issue. Not having any women in their 40s. Okay, the first thing I want to say, though, the reason I have this slide is I want to point out that if you look at the placebo group in these two trials, what really strikes you, this is to scale, is that the placebo group in the estrogen-only trial had many more events than did the placebo group in the estrogen and progestin group. So this is a real signal that the estrogen-only cohort is different from the estrogen and progestin cohort, and we can't say that the differences we're going to see in outcomes are because of progestins. We have to recognize that the placebo group is already showing us that these are at much higher risk for having the heart attack. And so the question then is, if you add estrogen to a woman who's really at high risk already, is this just a drop in the bucket? It's not going to have an effect one way or the other because she's already at such high risk. It's a question. We can't answer it with this study exactly. We do all kinds of statistical maneuvers, but the bottom line is this study had the increase and this was neutral. But as I said, I guess I thought I changed the order. So I do want to point out that stroke also was higher in the estrogen-only group by placebo, but the overall effect of estrogen and progestin was similar, and same with the DVTs. Basically, the DVTs and the PEs were higher in the estrogen-only group than in the estrogen and progestin group. So we attracted a higher risk group for one trial than we did for the other. Okay, now I'm going to get into what I wanted to get into, which is the age. This is what kind of started a whole new story and lots of activity, and this is what's come out this year. This analysis was run, and it wasn't significant. The interaction of treatment by age group was not significant. It was done by decades, not as a continuous variable. But what you see is this tendency that really got a lot of attention on this end. And what you have to understand is that when you have a significant interaction, it's because there's something different between these groups. And I think that we have to recognize that what was driving this interaction was as much the older women having more heart attacks as it was the younger women. And so there is a lot of interest in these younger women, and we'll get to that. But just to understand that this analysis is not saying it's all about the younger women. It's also saying there's a difference between younger women and older women. But that's where we are now, is there a difference? In the estrogen-only trial, this was published with a lot of emphasis on one cell, the coronary revascularization information, despite the fact that the overall interaction was not significant. That's not really legitimate. You're not supposed to do that. And I can tell you this got added, the emphasis got added at the final hour. It had already been through the WHI Publications Committee, it had already been through the investigator group, and it was really one of the authors added this kind of at the final hour. So a lot of emphasis got placed on this benefit. And then the question is, well, is this because estrogen is really helping younger women, or is it the choices that the medical community are making of who's going to get a procedure? And those are different kinds of issues. So it got very confusing right away. What does this actually mean? Now, what I started to focus on, and so I'm just drawing your attention to it because I don't have the answers to what this all means yet. We're very much in process of trying to sort through it. But something that I had been aware of from the very beginning when we first looked at the baseline data is that within these age groups, we have a lot of differences from age group to age group. First of all, the ethnicity is very different in the estrogen trial than it is in the estrogen and progestin trial. A much higher proportion of women with hysterectomy that came into this trial were Black and Hispanic, and it may relate to again, medical procedures, who's getting these procedures, what age are they getting those procedures, because it was really predominantly in the younger group. So when you look at the 50 to 59 group versus the 70 to 79 group, one thing that you can realize is that in the estrogen-only trial, there's a very high proportion of women of color, and compared to the other groups. So that's one big difference, to the point where when you actually look at the whole trial, the hysterectomy group, it's about 25% minority versus the 16% minority in the estrogen and progestin. The other one that was really obvious to me was the obesity issue. And I have to tell you, I did a lot of defending of the trial in terms of this argument that your women are too fat. But the women that were too fat were the estrogen and progestin trial. No one said anything about anyone being too fat in the estrogen-only trial when it didn't show a difference. But what I want to point out to you is that not only is the estrogen-only trial, by and large, much more obese than the estrogen and progestin trial, but there are these huge differences by age group, which further confounds the data. More than 50% of the women that were in the 50s in the estrogen-only trial were obese, not just overweight, obese. In fact, as you see, only 20% of that whole trial was normal weight. And a much lower proportion of the older women were obese. So these are things that are confounding this story big time, and what we have to do is be very careful how quick we are to rush to making new recommendations for everybody based on the WHI. And so I am willing to acknowledge that the WHI is not answering a question for thin white women in the same degree that we might be expecting, and this is something that we have to come to terms with. But to move on, basically to summarize the secondary analyses by age, we were kind of in this position where we saw this non-significant reduction in the women who were less than 10 years from menopause. That was in Joanne Manson's 2003 paper. No clear trend with age for E plus P. This is the E plus P trial. And they did have this increased stroke that was not modified by age. The other analysis that we had is the estrogen-only trial, non-significant reduction in these younger women, significant reduction in these revascularization procedures, no clear trend with years since hysterectomy, and the increased stroke. So we were kind of in a position where we felt that we would like to really look at this even more, but you need more women. So even with a study as big as these two trials, the numbers aren't big enough. And so we tried to figure out how can we pull these two trials together, recognizing all of the things that are different about the trials. And so this is the paper that came out in April that you have the reference for here. And basically, I won't elaborate on these methods, but I can make my slides available to anybody. These models don't make assumptions about baseline risk or the overall treatment effects in the two trials. They're coded categories by age and years since menopause that were fit to a linear model. And I can tell you we spent 2 years trying to get the right model to do this. So the statisticians were working on this, and we were trying to do this as best we could. The unadjusted models were used because there was no difference between adjusted and unadjusted, and we used a little more stringent criterion for significance because of all of the different testing. Now, we already knew that the baseline risk was higher in the estrogen-only group, and we knew that the overall hazard ratios were different. So that's 2 strikes against pulling all your data together. But the trends for the hazard ratios across the decades of age or years of menopause were actually similar, and the overall stroke hazard ratios across the categories were similar, and we basically convinced ourselves that we could pull these two together. And so we used these Koch models. All right. I'm not going to get into this. I'll just say that we did analyses looking at hormone status, duration in the trial, adherence, and what I want to do is kind of jump on to what do we have. So when we pull these data together, these are the kinds of numbers that we can work with for the 2 questions that we had on the table, which was age and years since menopause. Now, the years since menopause issue is a really important one, especially in the estrogen-only trial, because what you'll see later is the average age of menopause because of surgical menopause was 43, and the average age of the women that were at least in the CAC study you'll see, was 55. So by and large, these women were already more than 10 years past menopause, even in their 50s, because of the time that they went through these hysterectomies. So you can see that distribution. These numbers I've put on the other slides too. So the first thing I want to do is just say a little bit about the baseline characteristics coming in, to just point out that in the hysterectomy group, about 36.5% of them had had a bilateral oophorectomy. By and large, these were women who had this at much younger ages than the older women in the hysterectomy group. And then 56% had not had a bilateral oophorectomy. And there's a lot of confusion about, these numbers don't add up to 100%. And if you've ever done this research, you'll know why. It's really hard to figure out what do they really have left there. Do they know it? But at any rate, this is what we know to be sure. And what you see is that in the younger group, the 50 to 59 group, 70% of the women who had a bilateral oophorectomy had prior hormones use. Compared to a slightly lower proportion of the women in their 70s. And all of those were much higher, the prior hormone use, than women who had never had it. So this is another confounding issue on this whole story is the bilateral oophorectomy. And this is in the estrogen-only trial. And then in the estrogen and progestin trial, a much lower proportion of those women had ever been on hormones. The other question that I'm going to address is menopausal symptoms. The other thing that we heard a lot of was, your women don't have symptoms. They don't have, this is irrelevant because they don't have any menopausal symptoms. And of course, a lot of them were 70, they were already past menopause. They weren't happy when they started getting symptoms when they came off the pills, so it wasn't a great thing to do for them. But we did in fact have a substantial proportion of women, especially the younger women, who came into the study with at least mild and a high proportion with moderate to severe menopausal symptoms. And that was true in both trials. And the reason that I'm showing you the symptom data is that it turns out that it makes a difference. And so we're going to come to that, and this is, I think, one of the new issues that we have to figure out is who has menopausal symptoms? Are they biologically different? And we'll come to that in a moment. Okay, so there's a lot of tables, and I apologize if you're not that comfortable looking at these kinds of things, but what I want to do is kind of just home in on when you do the pooled analyses. So this is looking at cardiovascular and the global index in the combined trials. What really pops out is that stroke, when you put everyone together, is definitely a bad thing that's going to happen to women who go on estrogen and progestin in a much higher proportion than is a heart attack. And the global index is actually still in a direction, not exactly significant because it hits 1, but it's still in a direction of harm. So we still have this when you pull all the data together, even with the benefits that we see in estrogen trial, there's harm. But that's not going to be satisfying because you're going to want to tear it apart. So we'll get there in a moment. This is just looking at the excess absolute risks so that you see that everything is in the bad direction, except in the estrogen-only trial, there is, not significant, but there is this decrease when you pull everyone together. And so this is where we have to start to figure out what is going on. Is it the cohort? Is it the estrogen? What's happening? Okay, but the question here relates to age. And so what I want to do is home in on where a lot of attention got played. A lot of attention got played to the death in the younger women. And I think that most of us would agree that younger women aren't expected to die. So it might be an important finding, but I don't think that's really where the focus should be. I think the focus should be on the fact that if you start these hormones in older women, that's really the problem. And I think that instead of focusing so much on trying to get some sense of benefit for younger women, we should realize that what WHI has clearly done, and I don't think there is any controversy there, is it's stopped people from starting women on hormones when they're out in their 70s. And I'm going to show you that it's particularly true if it's a woman who's having menopausal symptoms in her 70s. But to move on, these are kind of looking at the data combined and then by separate groups. And what you see is that the estrogen and progestin trial, this is now looking by age, doesn't give us any sense of difference by age, whereas there's clearly something suggested in the estrogen-only trial. So a lot of attention went to that point, and because of that, we actually did a whole study on coronary artery calcification that I'll show you. We don't actually see a significant difference or anything happening with stroke, especially in E plus P. This is neutral. It's not saying that it's reduced, so we shouldn't see that as benefit, but it's not significant. Okay, so then this is looking at years since menopause, and what we see is years since menopause, which is very highly correlated to age, looks a lot like older age, and years since menopause is on the younger side, on the less than 10-year side is correlated with age. And so we're seeing an important point here is that the stroke is still 77% increased. So this is where we're feeling like, wait a minute, we can't go around telling women they're fine when we have this less than 10 years since menopause problem, and the fact that the 50-year-old women in the WHI are more than 10 years past menopause in some of these cases. Okay, so this is looking at those data again in a different way when you pull everything together, and what you see is be sure I'm looking at which one I'm saying. This is the year since menopause group. What you see is that it's really years since menopause more than age that is driving a lot of this action, but not for stroke. Okay, so to kind of put these two things together, the coronary heart disease by age group and prior CVD status, this is basically looking first at the age issue, and then this is adding on top of it the prior use. And what you see is a very interesting, the year since menopause is clearly giving us more information than is age. Again, a very complicated slide, but I think I can home right in on where the action is, and the action is in the older women not doing well when they're going by age and being more than 20 years past menopause. So I think the real focus is, although a lot of the publicity was on younger women, the data are really about older women. So that's the bottom line. This is the whole story in one slide for the age issue. So you can take the ages for each of the categories, and I'll give you some time to study that so that you can actually try and work your way through it. I think that what you're seeing is that for the E plus P, it's clearly the older women that's driving that. Even for the E alone, we don't have a very strong story saying that there's this huge benefit, but it's there. So it keeps, I mean, it's the same data, so of course it's going to keep showing up in the same way. But this is where that story has gone. And I think that we do need to really do the two apart more than the two together for the reason of that's how you're going to treat people. That's by age, and then again to show years since menopause, it's actually a somewhat stronger story that the longer you are from menopause, the worse off you are with respect to an effect of estrogen when you start estrogen and testosterone, estrogen and progestin. So to summarize this before I get into the CACs, the principal findings that we have from these new analyses is that when women start hormones close to menopause, they may have fewer heart attacks, and that's where all of the attention has gone in the media, and they may have fewer deaths if they start hormones, compared to the older women, and it's really because the comparison is against the older women, and that's where the real action is, the real increases. So we're trying to make a comparison where it's really because it's not the glass half full story that we would like to get out of this, I think. I personally think that, but I would love to have a debate about it, or not a debate, a discussion. I won't get into the breast cancer issue. That said, it does provide some reassurance, and I think that's as far as we want to go, as we want to say, yes, it's not likely that a woman is going to have a heart attack in her 50s. A question that we're now asking is, who are those women that are having those heart attacks in their 50s? And that's something I really hope the cardiology folks can help me work my way through. What do we need to be looking at so that we can identify the group that's really going to be in trouble here? But I think we're pretty comfortable with this short-term relief. And that for older women, I guess, did I show you the hot flush data? Oh, I did. I'm sorry. I did? Okay. I think I did and I forgot to emphasize it. That was the worst group. The absolute worst group is older women with hot flushes. And so that's a group that's out there that's now coming back and saying, I need to go on hormones, and we're getting all this reassurance that it's okay to do it short term, but it's not okay for older women with hot flushes. And what we need to do is find out who are those women and why is estrogen increasing their risk of having a heart attack. Let me do questions afterwards. I'm almost done. So what I want to do is just tell you that because of this 50 to 59 group, we actually went ahead and decided to use our core resource funds, which WHI has some funds at its discretion, to do a sub-study of just the women who are 50 to 59. And many of us would have liked to have also compared it with the 70, 79-year-olds, but we focused on this group. And this is a group that's actually being studied now in other trials. So when people say they should study younger women, there has been a study called EPAT that was looking at carotid intramedial thickness that did have a positive outcome. There are 2 trials underway, ELITE and KEEPS. ELITE is funded by the NIH. KEEPS is actually funded by an independently wealthy philanthropist who's looking at this question, and they are looking at intermediate endpoints to see if you start younger women on hormones, will you have a better outcome? But they're still focusing on heart disease, and I think that that's personally not the most important question, but that's the question being asked. That said, we also wanted to look at this question. So we conducted the coronary artery calcification study, and that study had 28 of the 40 WHI centers. So Stanford was one of them, and Jeff Rubin, I don't know if he's here, was very key and instrumental in helping us make that happen, and actually lots of people had to work with us. So if you try and do these studies at Stanford, it's not as easy as you think. But anyways, fortunately we had good colleagues, and they helped us get this thing going here. These are the numbers of women that were 50 to 59 at those 28 sites that were eligible to be in the study, and you can see that a high proportion of them agreed to come into the study. There were some problems with who were the women coming in. They were by and large a healthier group of women than the women that weren't coming in. So you have all of those kinds of biases, but the strength of the study is this huge number. And this was a one-time look. And I didn't make the slide that I meant to make, which is to tell you that by the time we did this one-time coronary artery calcification, they had been on hormones on average 7.3 years, and they had been off hormones an average of 1.3 years. So it's a 8.6 year total picture, but with a big chunk of time on hormones and then over a year off hormones, and it's just looking one time. And these are the characteristics of the women. So I want to point out a point that I made before is the mean age was 55 and the age of their menopause was 43. So these women were already more than 12 years past menopause. If we're really trying to answer the question at the time of menopause, WHI did not do that, cannot do that, and someone else will have to do that. But a lot of press is being made as if we did do it, but we didn't do it. You can see here the age of hysterectomy, how that plays out in these women. Again, these are only the women who are 50 to 59 in the estrogen-only trial. So this is not the estrogen and progestin trial. Again, a high proportion are black and Hispanic. When we look at body mass index, as a group, they are obese. A high proportion have hypertension, and a high proportion have diabetes. So that's who they are. And this is kind of a nutshell. There's a lot of tables about each of these data points, but I just wanted to kind of home in on this, that when you look at coronary artery calcium score, for those of you who aren't familiar with it, calcification is some measure of atherosclerosis, and I really do hope that some of the cardiologists will stick around and we can talk through what does it really mean. I think many of you came to the talk that we had Noelle Berry-Mertz give, where she was introducing the idea that there may be a different pathology in younger women, but that's a big maybe, we don't know that. What we have to figure out is, what does the coronary artery calcification mean? The vast majority of women had 0 scores. So more than 50% had zero calcium, despite all of those statistics I just showed you on their obesity, hypertension, and so on and so forth. So we kind of went from cut points, looking at 10, lower than 10, above 10 as a cut point, then going 10 to 100 as a cut point, then 100 to 300 as a cut point, and then over 300. And the reason we ended up publishing all of these cut points is that the literature is not clear on what is the cut point. Where do we define atherosclerosis on these coronary artery calcium scores? But I think what you really can see is that in the intent to treat, there's a clear, as soon as we move away from the zero and move on into it, the higher that cut point, the more we see that the women who had been assigned to estrogen at the very beginning of that 8.3-year period had significantly lower coronary artery calcium at that one-shot look. And when we did the adherence analysis, where you only look at women who were taking their assigned pills, so that's the placebo taking the placebo pills, the estrogen-only group taking the estrogen-only pills, you see an even more significant effect. So this is a new question. What does it mean? Is it giving us evidence of benefit? What we don't know is, how do these calcium scores play out over time? How well do they predict who's going to have that heart attack in her 60s and 70s? These are all new questions, but what it is not, in my opinion, is the answer that if we start women on hormones, we're going to protect them the rest of their lives and we're going to reduce heart disease. And so we've gone the publicity, in my opinion, went way beyond the data, but the data this is what people would really like us to start to explore. So we've done the best I think we can do, although I think we've continue to confuse people, and so that's the problem. So I'm going to kind of bring this to a close and say that the data suggests that hormones, and this is when you look at the combined analyses, that's where we use HT, otherwise we would say estrogen only, that the combined analyses do basically support that if you give them for 4 to 5 years or within 10 years of menopause, it's relatively neutral. Not beneficial, neutral. However, in women that are farther away from menopause, starting hormones does increase their risk. So is this because of age? Is this because there is a change in the arteries over time because of being exposed to estrogen or not? It's a question. But especially if women have this biological issue of having vasomotor symptoms in their age. So there's something there that I think we should kind of try and home in on. And the question that everyone has is, what if you initiate hormones within 10 years of menopause and you continue it for several decades? We didn't do that, and a lot of women who were doing that in their own natural experiments stopped on July 2002. So who knows? But at any rate, we don't see it as a good candidate for prevention. So what I'm going to kind of end with is this issue of the progression of atherosclerosis and what role does estrogen play in this. So that if we look in the young adult, we have this initiation of atherosclerosis, we have the fatty streaks. As we move on in, we start to get raised lesions, and as we get older, we get complicated lesions. Is there some point along this continuum where estrogen is actually benefiting the arteries and then suddenly it goes the other way? That's the question people are asking. But we don't have any data to really address that. So we have everybody believing it now. They say, well, it could be this, and then suddenly it is that, as opposed to it's not a hypothesis worth testing. And I will say that if you want something that's really good for prevention, you would like to see that it's going to reduce the problem at all of those stages. And you wouldn't want something that's going to have a flip, and you don't know where you are in the midst of that flip. So I think that's a real challenge for us, and that's basically the idea that it's age, but I've already pointed out years since menopause is part of it. The years since menopause issue is confounded by who is getting a hysterectomy in the estrogen-only group. I think that's a huge part of it. We already have from the observational study very good data that women with hysterectomy have much higher risk for heart disease than women without hysterectomy, even when you match for age and all these things. And so there's something about that population that's getting the hysterectomy that is underlying this difference. So in end, age is a powerful risk factor. The older we get, the worse off things are going to be. Prevention is really aimed at slowing the transition, and so if we're really trying to look at prevention, I don't think estrogen is a good candidate. We don't know where it's going to have its effect. And this I only put in there because I took out the slide that gave you the evidence. So with that, I'm now, implications for treatment. I guess I should do that. I already said that we basically have fallen in line with the idea that this is not something that's dangerous for women in their 50s. For women as a group, I think it still is dangerous for some women, and I think that we have to really do that. I think you all do that now. You individualize your message. I think that we're real clear that it should be avoided you should avoid starting it in older women. I think that's the biggest message, especially if they have vasomotor symptoms. The vasomotor symptom, I think this is something that's a new area to explore. Is it a marker for CHD or not? I think that's a great one for the combined community of cardiology and OBGYN to take a look at. And we basically stick with the bottom line that you're not going to do this for prevention. So, and I think I'm done. Yes. So that was a lot of data, but I think there are some simple points, and hopefully you got them.
That was spectacular, Marcia. Thanks for that. And the body of work that you've done with your co-investigators here has just been so helpful to us as clinicians. I just have one comment about the coronary calcification, and it's quite a paradox that you have such a striking reduction, or a striking reduction in the hazard ratio of having coronary artery calcification if you're on estrogen. Yet there's not a striking reduction in cardiovascular events, and that's interesting.
Well, actually, so the issue is that in the estrogen-only group, in the women in their 50s, that is the place where the clinical outcomes suggested this benefit. So that's different from the whole trial, and that's why we did it. So the one problem is that we did do it in a group of women who we already knew that their clinical outcomes were lower. So it's...
No, what I was saying is that there's a striking reduction in coronary artery calcification. We're down about 50%.
Oh, and not a striking...
Not a striking reduction
yeah.
in coronary events. Benefit seems to be pretty modest. So that's a paradox. Because that level of coronary calcification you're showing us, that extreme end, over 300, those individuals typically have a lot of coronary artery disease. People talk about, what is the meaning of coronary artery calcification, but certainly at that level 300, those individuals are at high risk of having a coronary event. And you've reduced their risk of having that coronary calcification by 50%. It's really true. So it's interesting that there's not a concomitant reduction in coronary events.
Well, and so one of the things that I'm proposing now for WHI is that we try and find out how did these coronary artery scores, these calcium scores, predict future events. So to continue to follow this group and do another CAC, we call it CACs, a coronary artery calcification study down the road to see, did it even predict the coronary artery calcification? I don't know if that's worth doing, so I would love to hear your thoughts on that. But it is a paradox. It's a dilemma.
Do you think it has to do with numbers? And the smaller number of women that were actually in that category with such high calcium score to begin with, that we're just not seeing the outcome?
Yeah, I don't know. I mean, it's significant. It's pretty significant. So I don't know. I don't know.
I do have one thought about it. I mean, estrogens do reduce calcium flux out of bone, right?
Right, and this is a very interesting issue that we're looking at now.
You're reducing calcium flux out of bone, and you're just reducing calcification of lesions that are there. What happens with the coronary calcification? There are cells there that are like bone. They make a matrix that can get calcified. So if you have, a situation maybe where you're reducing calcium flux out of bone, you're reducing the coronary artery calcification, but you're not reducing the lesions. So that's one possibility. The matrix is there, it's just not getting calcified in the patients that are on estrogen. And that may not have an effect on plaque rupture, for example.
And so I think that's the issue is this, how does this really relate to plaque rupture? How does it really relate to the heart attack as opposed to, I mean, we have a lot of questions now. And I think this bone issue is one that a lot of, you know, there's some literature now looking at this relationship of these two phenomena. So that's kind of where we probably need to take a look next. Let me answer a few more questions. And then, seriously, we would love to have as many people stay for the roundtable discussion, because I'd really like to get into, like, what do we do next? What would you like to see us do?
I understand that it was a very striking difference in the incidence of heart disease in the women who had a hysterectomy versus who did not have a hysterectomy. And I'm trying to understand, how sure are we that that's really due to some difference in the women who have hysterectomy versus not, versus just the hysterectomy itself? I mean, the hysterectomy itself would be, in most women, you know, large numbers had oophorectomy, abrupt, sudden menopause, plus those who did have a hysterectomy may have had compromise, even if their ovaries were in situ, would have had potentially compromised vascular supply to the ovaries, and would have also potentially suffered from hormone loss having hysterectomy, even if their ovaries weren't removed. So it seems to me, rather than the difference like in ethnicity or something, can that really account for it?
Well, and I shouldn't have emphasized ethnicity. A paper that we did that was from the observational study, so looking at the issues of hysterectomy versus no hysterectomy, a very similar striking difference. When we adjusted the data for coronary heart disease risk, the difference went away. So the traditional risk factors are much, much higher in women with hysterectomy, which is why I said that, but it's true. I guess I can't prove that it's because that, and I don't know. I mean, I started asking people, what are the reasons for getting hysterectomy? And a lot of them, there's a lot of reasons. And so it's not a simple thing, and I shouldn't have said it so simply. But what we do know is that the women who, as a group, hysterectomy quickly divides two groups of women, women at high risk and women at lower risk. Within that, there's women with high and low risk, so you have your distribution. But there is a lot of questions about surgical menopause. That was something that came up in the literature long ago, that surgical menopause throws a woman into a cardiovascular state, and there's no good data on it, but that's kind of still in the literature.
That's on the agenda that I wanted to ask. Post-hysterectomy was associated with a higher incidence of Parkinson's syndrome. Does WHI have information that could help look at that?
On Parkinson's. Okay, so that's a really interesting question, because there's a group that's been trying to do a Parkinson's study. It's a rare outcome, and so to get those rare outcomes in a study of this size, so in a study of this size, it's a little bit more challenging to collect those data, because we didn't collect those data the right way, right from the outset. Where's Joyce? So she knows about how we collected our data. We just today approved a protocol where we are going to send to our IRBs a request that we can actually have the coordinating center contact women with rare outcomes, including Parkinson's disease. So the Parkinson's disease question has been waiting for 2 years. So there's a person who really wants to do it, and I hope that within a year we'll have the answer to your question, but I don't have it now. And other rare outcomes, too, we're trying to get our hands around that.
You didn't do the coronary artery calcification scores on the older ones, because then that would give you sort of a comparison of maybe it does even go down in the older cohort as well.
Yes, right. I very much wanted to do that, and it was logistics. Within the WHI population, we have a lot of differences of opinion, and the other side prevailed. But I agree with you that we should have done it. I wish we had it.
On the basis for the older women, were they women that only began taking the either treatment group at 70? Or had some of them been on it?
Yeah, I showed a slide like that, but I was showing lots of slides of their prior hormone use, and about 25% of women had been on hormones before in the 70s, and about 20, yeah, so actually,
On and off and on and off. Does that happen?
yeah, we don't have good data on and off, and we have good data on years, duration of use, and doses and things like that, but we don't have good data on if they're going on and off. It's a hard question to ask, especially if 16,000.
The older women, some of them had been on it for 30 years. 20 years?
Most of the women had not been on, most of the older women had not been on hormones for really more than 10 years. So a lot of these older women had been the interesting thing about WHI, people say, you know, we don't start young women on hormones. Well, in fact, in the 90s, lots of people were starting older women on hormones, and they didn't like it. So we were getting women who were kind of facing this decision, should I do what my doctor wants me to do, or should I do what I want to do? And we could say to them, you have a 50-50 chance. 50% of you will get hormones, which apparently your doctor wants you to do, and 50% of you will get placebo, which apparently you would like to do, so it's a win-win. And the answer to your question, should you do it, is we don't know. That's why we're doing the study. So we did have a proportion of women, but the older women probably, relatively few women who had been on hormones for 30 years were willing to come off hormones to be randomly assigned. So that's another problem, and we acknowledge that you always have a problem. Who's coming into your study? You know, why would they be willing to be randomly assigned to this? We had that in hers too. And in fact, hers was a real kick because you'd have women who were in their 70s calling and saying, I'm bleeding. You know, why am I bleeding? It's like, well, you have a uterus and you just took hormones. It's like, but am I going to get pregnant? I mean, it was like really interesting phenomenon. I mean, they weren't ready for that at all. And older women aren't really ready to start that all over again. So the good news is that estrogen and progestin just didn't come out to be something that you'd want to do anyway. And if you have a hysterectomy, if you're young, it seems like that's not so bad. But we're kind of stuck now with, we've got 3 or 4 different messages instead of the nice, simple one message.
Could you talk a little bit more about the weight BMI issue and the differences in the sort of the continuum of weight in this whole huge population of women? Where did it seem to take an effect? And
you know, the interesting thing is that at least in the estrogen-only study, we weren't able to see an effect of weight. I think it's because we had too few, where, you know, the numbers were smaller. I don't know. I mean, we've been trying to work our way through the weight issue. We certainly know that that's related to diabetes and it's hypertension and these other things. And my sense is the problem is what the AHA always had with weight is once you start adjusting for those other things, what weight is actually driving has been adjusted for in some other way, and so you can't see it come up by itself. It's not a very good answer, but...
But the E plus P group actually resembled the general population.
The E plus P group resembled the general population quite well. It was really the estrogen only. That said, I made that point once and someone said, well, how do you know? I mean, what data do we see by hysterectomy status in the BMI literature? We don't see very much of that. So we saw it in the observational study, yes, the hysterectomy women had much higher obesity, but when you hear the population data, we don't get population data by hysterectomy. So they may have been very representative of the US population of women with hysterectomy. And that's what I mean, when you start getting into these dilemmas, you start to realize what we don't know, which is a lot. So if we're going to do a round table, maybe we should be round, or do you want me to stay up here? What would be the most comfortable for those of you who want to keep talking?
This is what
Or you can stay where we are. Okay, I'll stay up here. So what are the questions now that you think, do you feel that we've answered some? Do you feel that we've really raised more than we've answered? Where are we, Jennifer?
I wanted to throw something out which may be a question, but I'm interested in the revascularization group, so the small benefit in younger women with less revascularization. And I wanted to throw out the whole thing that we know about low estrogen and anginal attacks, and that women, when their estrogen goes low, they have more angina. And it may be that by virtue of having taken estrogen, they had less symptoms and were less likely to get to revascularization than someone not taking estrogen.
So you say...
So it had only symptomatology rather than development of atherosclerosis per se.
Well, it's interesting that you say that because what Framingham got criticized for was including angina in its definition of heart attacks, and they're the ones that said that it increased chest pain and angina twofold. So I'm curious that you're saying that estrogen reduces angina, but it does?
States is when women tend to have more angina. So if they look at women, at least who are still having periods, menstrual periods, and they watch their cycles, that during times of low estrogen is when they have their symptoms. So, it's just of interest.
Yeah, that's,
Do you think that's vasomotor, or do they think that's actually like atherosclerosis?
I don't know if they got that far. It was mostly monitoring. There are a couple of articles I have on it. It's not a heavily studied. But I have a couple of articles and we can look closer. But yeah, I mean, that's certainly what comes into mind is the whole idea of you talking about these vasomotor symptoms and that sort of thing and how is that related. The endothelium is supposed to be healthier with estrogen around. And if the endothelium is not as healthy, then you're going to have more constriction of the vessel, then you're going to have more symptoms. So,
Well, that's certainly the monkey data that was so sort of compelling prior to hers, just in terms of endothelial function and estrogen in monkeys, was, you know, a lot of some of the data that I think got some of the earlier studies going.
well, and in fact, the monkey data, the monkey studies is where this whole idea of
Benefit.
the timing issue, because they did a study where they actually did the oophorectomies on 2 groups, and they gave one back estrogen right away and the other one they didn't, and then they gave it to them later and they saw a different response. So they saw that if you kept the estrogen, you get this benefit, which is basically measured by aortic thickness, is what they do these cross slices. Now, an interesting thing about the monkey data is I actually reviewed that paper, and the first time it came to me, there was no control group. And then it came back to me with a control group. So I'm very, you know, I kind of feel like science is not as good as it should be. So that's a little bit weird. But anyway, the monkey data is where they really got this idea that this, you know, you need to do it now, and if you don't do it now, you've lost your opportunity, and if you introduce it later, you have a problem. So this is the hypothesis that came out when hers came out. So the very first reaction that they had to hers was, well, the women were already too sick, and if you add the estrogen in a person who's already got atherosclerosis, they'll have a heart attack. And a slide I didn't show is where they said, and that's the problem with WHI, because they were old, they already had atherosclerosis. And we have this great slide where you see what the rates of heart attack are in women who've had a heart attack, which is 10-fold higher than a woman who's not had a heart attack. So they clearly are very, very different in terms of your likelihood of having it with or without the estrogen.
With coronary calcification, because we only did one snapshot in time, is it possible it's reflecting, you don't exactly know when it's occurred, and if those plaques are less likely to rupture, would there be potential value to doing sequential coronary calcium? And also, could you just comment, I guess, what exactly were you hoping to determine with that?
Hoping to see, that's the way the way we do science, is we hope to see. Well, I've learned that lesson. So Joanne Manson, who's really the leader of that study, was hoping to see what we saw, which is, you know, basically that was the hypothesis, is that the women who had been on estrogen would have less coronary calcification. I don't know what I was hoping. I was curious to see whether we would see it or not. And I have to admit, I was surprised that it turned out to be the direction of the hypothesis, mostly because I've been doing hormones so long and nothing ever turns out the way you expect. But I was surprised. And in terms of sequential, that's what I was trying to ask John. Is it worthwhile doing another one? The problem is, it would have been best, obviously, to do it at baseline before they were randomized, and then have 1 point before they stopped. I mean, we all know that's what we should have done, but we weren't looking at surrogate markers. We were looking at the hardcore outcomes. So in retrospect, I wish we had that, and I also wish we had in the older women that she said.
In that same group, the reduction wasn't significant, was it, in terms of the plaque?
The coronary artery calcification was significant. Yeah, and it got more significant as you had that score. When the calcium score was less than 10, it wasn't as significant as when you got to 100. So when you start to get into more major disease, that's where you really see the difference. And that, I think, is what John was talking about, is the 300. So it was significant, and especially when we did the analysis of adherence, so women who were actually taking the pills. Because one of the problems with the study was a lot of women stopped taking their pills, which is the way the population's going to be too. So even if it turned out to be the best thing that ever happened, we'd have trouble getting women to take it.
Are there any other risk factors that were identified in terms of, is there more or less hypertension or diabetes or?
So in the Joanne Manson's 2003 paper, we have all the risk factors, and I took that slide out too. That did show, very much like Pepi and hers, increased HDL with estrogen, decreased LDL with estrogen, increased triglycerides. The risk factors, all same with coronary. The risk factors, by and large, except for triglycerides and C-reactive protein, look better. And that's the problem, is we were looking at the risk factors instead of the hard outcome. And then the other thing that's interesting, in the actual paper, if you've seen the actual paper from the New England Journal of Medicine, there's a figure, we call it figure, those figures that have, how you line up the relative risks on, whether it's on this side of one or that side of one. There's only one of those two sets that's actually related to the hormone trial, and that's the one that's the significant difference, significant reduction in coronary artery calcification. But the rest of that slide is about how the women at risk, independent of whether they were on hormones or not, independent of whether they were on estrogen or not, line up with coronary calcification. And it's amazing to me. I mean, I also was not so sure I knew enough about coronary calcification to trust it as a risk factor. It was so tightly related. So women with hypertension had much more coronary calcification, women with diabetes, women with low HDL. I mean, all the risk factors ended up lining up very strongly with higher coronary calcification versus women that didn't have them. So the score in that population was really pretty well matched to risk. And then we have the one thing that was the hormone piece. So look at that if you're interested in coronary calcification, because that was kind of, oh, I guess it must be good. I mean, it must be true. I mean, I had to accept that my hypothesis was wrong.
But I think John made a good point though, Marcia, that it may just be that the calcium's not there, but the actual atherosclerotic process and risk may still remain the same. It's just that the uptake of calcium is somehow different. And so, I mean,
Yeah, and so this is where I started asking Jennifer about this issue of the other kind of pathology that they claim women have. We don't really know that men don't have it yet, but young women are the ones that have been targeted for this microvascular disease as opposed to the obstructive. And we couldn't really, I don't think, I also called Jeff Rubin, and I talked to him for an hour the night before this came out, saying, well, can you see the calcium in those small vessels if there's calcium in there? And he goes, well, you can't really tell if it's in the small vessels or the large vessels. Apparently there's a brand new machine coming to Stanford that's going to be able to tell that. Did you know that? So there's a new machine coming. Yeah, so there's a new machine coming that will be able to let us look at large vessels versus small vessels. But the calcium, and I think you're making that point, it doesn't tell us enough about what plaque is about to rupture, and if maybe it isn't a ruptured plaque that's the important issue, which is one reason why I want to look at what is going on with those women in their 50s compared to the women in their 70s for their heart disease. Most likely all the things are end up being the same. It's HDL and LDL and everything's going to come out that way.
Calcium, it's a tendency, they do have a higher future risk of an event, but we don't know exactly why people lay down calcium. We'll see some patients, their entire coronary tree is just heavily calcified and somebody else won't be. And we don't know why is that person more than someone else. And patients always ask, they're like, is it because I'm taking calcium supplements or whatever? We don't have evidence of this from what you take in. But I think the whole calcium issue is still a little vague, or we don't know the answer exactly. So, and I think it is a good point that maybe estrogen is keeping you from laying down calcium, but not necessarily developing plaques. So who knows?
Well, an interesting issue that comment in John's is I'm realizing that we have at least a subset. There'll probably be a small subset, but we have a subset of women that we did bone mineral density and we did all those bone assessments and we have at least vitamin D in their blood, we could start to look at, is there any relationship with the other part of calcium? I should go to the endocrine group and ask them to help me figure this out. You can see I'm really eager to figure it out, so if you have any insights, help me.
Yeah, I mean, people wonder why do these tiny little osteoporotic women have these really heavily calcified coronaries? You know, it's like, why is the calcium there and not in their bones?
Well, and that would be interesting if there's a real correlation.
Marcia, did you? Sorry.
Mihar.
Yeah. If you look at the uterus, particularly androgenesis and atherogenesis, the male nucleus, which mediates actually the effect of the hormones, are mainly the adventitial layers, the fibroblasts, and the Calcification cells. Not really the endothelial cells or the muscle cells. They are indirectly regulated by so many surrounding cells. So is there any direct study in the adult, whether these cell types are altered directly by hormones or anything happening in the premenopausal versus postmenopausal?
Not in WHI.
At the first stage, but we see the effect of the steroids not directly on the endothelial cells, but the surrounding cells, particularly the local factors are the key players. That's why we see a dramatic effect of androgenesis and atherogenesis in the uterus, not throughout the body. So if we extrapolate the same situation, if there is, I would expect a big alteration in the surroundings of the arteries, not in the abdomen. So
I don't know, why don't you do me a favor and look in that literature, and if you find something, tell me, because it's...
Well, basically,
Increased
when there is a history, there is more androgenesis in the
more
uterus.
angiogenesis with estrogen.
Whereas when in the secretary,
In the uterus.
there is more atherogenesis. And that of course kind of the local effect only in the uterus, not also at the uterus. At least to that extent. So it is the local factors, particularly the adventitial layer, the inflammatory cells. There are a lot of studies and research. They are the key players. They release most of the local factors which regulate these processes. So if I would expect in latter stages when there is in premenopause versus postmenopausal cases, there must be some alteration in the other cells, whether they be parts of the inflammatory cells. They are contributing to it, or the adventitial layer, particularly those that are they have the direct nuclear receptors for these hormones, and they are the key players in regulating these processes. So is there any study to look at later stages where there is change in the receptor pattern or the adventitial layer or anything in that?
Well, I think you mentioned that, so the question is, since we know estrogen has positive effects locally, at least when women are not postmenopausal, what about later? Have they changed their receptors so that estrogen is not as effective? Or has the disease progressed to the point that receptors have disappeared, that sort of thing? Yeah, I think that's one of those big questions that people are wondering is, because we know estrogen has a lot of positive local vascular effects, which is what started this whole thing, I would presume, in the very beginning.
Well, I think what started was HDL and LDL. I mean, that's the story was all HDL and LDL in the beginning. And then it just kind of went from there to the endothelium. But the arteries that are in the uterus are so different that well, you know better than I do how different they are.
Not really, there is nothing very specific to the endothelium or the smooth muscle cells. If you take out those smooth muscle cells or endothelium, they behave exactly, in the culture system, they behave exactly like other endothelial cells. So it is the adventitial layer, the fibroblasts, the inflammatory cells. They are under the influence of hormones, they actually regulate these processes. So if you take endothelial cells and put them elsewhere from the body and put them in the uterus, they will behave the same way like the uterine cells, not different.
Wow, that's interesting.
So that is why I'm asking why we don't have. I was looking for the literature. I didn't really find much information. And the adults, how other arteries and veins or other systems are regulated by steroids. There's no clear insight.
Well, we don't have anything like that in WHI. I think that's more of a literature search thing, but I would welcome that. I mean, anybody who's interested in following up. And WHI, by the way, I meant to print this out for you. We have a huge resource. We have a lot of blood. We have DNA. We don't have, we have white cells, but we don't have, real cells. We don't have any tissue. But we have a lot of great data that we can explore, and there's actually special funds. There are these broad agency announcements for special funds that are like $1.5 million proposals, and there are going to be another round of them in 2008. So if you think of anything that we could really go after, I'd love to do it.
Well, one of my suggestions is there should be some stimulus actually to look into these factors, because these are the basic clues which will allow us to go further.
Well, I'll send you what we have, and if you can figure out what to measure in that, then we can try and get our hands on it.
Are there thoughts among the investigators about the increased stroke other than, I mean, there's this increased thrombus formation, but generally stroke is an atherosclerotic process, and that we think the PE may be more related to thromboembolus. And I'm just wondering, why do we see higher stroke if the coronary disease is not necessarily any more severe?
Yeah, well, I think in the E plus P it went in the same direction, but I think in the E alone is where they kind of deviate. Lots of people have said that. How come you're not seeing the same thing with stroke as you see in CHD? I don't know. That's where the body mass index turns out to be hugely related to who's getting stroke. So that's like the strongest predictor of the strokes.
In hers, they couldn't figure out, they looked at 117 clotting factors or something like that, Jennifer, and they couldn't figure out why there was a, was it a thrombotic issue, or was it atherosclerosis and thrombosis? And they came up with nothing from hers.
Yeah.
Estrogen and progestin. So.
We did that in WHI too. We haven't published the biomarker data yet, but I'm actually, we have one that's, I'm not sure where it is, the CHD and biomarker one, but we started out with stroke and CHD, and they were so different that they're not the same, and I don't know why. I don't know if it's an estrogen thing that makes them different or what, but I think that's an interesting area too.
I had another question. So I noticed in reviewing the CACS article that almost 40% of the original cohort was not included. Does anybody think anything of that or not?
Well, the reason was,
given the exclusion criteria, which included having had revascularization or having died and that sort of thing.
well, so the first reason why so many were excluded was because only 28 of the 40 clinics participated. It was an ancillary study. So that cut out a whole bunch. Now, unfortunately, it actually cut out a lot of the minority centers. But we still had a high minority group, so that was interesting. But the main reason that so many women didn't come in was they weren't there. But maybe that's not what you're talking about. Maybe you're talking about the 1,700 going down to 1,064. Right. Yeah, which women were willing to come in and do that?
Well, and their exclusion criteria, like I said, was a lot of cardiovascular things. Revascularization, death, I don't remember if MI was in there, but there were a good number that were eliminated because
yeah.
they had some sort of cardiovascular event, which
yeah, and we
it was fairly similar between the treatment and placebo, although it was actually, there were, the placebo group had 10% or 10 more patients that were, I don't know, or 10 less or that had been excluded or something like that. So it might not have changed the numbers, but
yeah. And we didn't, well, when we put out the call for women to come in, we didn't distinguish between who was a placebo and who was hormone. And it did turn out, I'm not sure if you saw that, but the women who came back in, by and large, had been more adherent to the pills, which isn't surprising. And then there was a difference between the two groups. So the women that had been on estrogen had been more adherent than the women who had been on placebo. I mean, there were kind of some other problems, but we did a lot of statistical adjustment. And, you know, one day I'm going to sit down with a statistician and have them explain to me, like, what really goes away with these adjustments? Because I think the adjustments, we have this idea that then we've taken care of the whole problem, and I don't think so. I think we've just kind of like, I don't know, I'm not a statistician, but we did a lot of adjustments to deal with the adherence thing because that really disturbed us. Like, who are these women coming in? They must like being on estrogen, but they weren't still on it, so they didn't like it that much. But those are good points, and we did talk about that, especially since, you know, it didn't turn out the way I thought it was going to turn out. Any other questions? Well, thanks for staying for a little more discussion. And feel free to contact me. Thanks.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.